All right, everybody, welcome to treatment planning. Here we go. Let's dive in. Treatment planning, it's great. It's fun. Eventually, we're all going to have to do it at some point, likely. So, let's talk about at least some of the foundational skills. Now, every agency is going to be a little bit different depending on the system that they use and, how the directors want that done. But for the most part, treatment planning follows some of the basic similar principles. So, let's dive in. At least for this course, this is the treatment plan format that I'm going to have you use. This actually developed or draws from the treatment plan software that I use for my private practice, and that similar software is used by many agencies out there, so it's pretty common. So this definitely won't steer you wrong, and hopefully it'll, like I said, provide a solid foundation so wherever you end up, you'll have a good idea of some of the basic formatting. So let's jump in. I'll kind of identify some of the key elements by this little animation, this little figures, and then we'll go from there. So one of the first things you'll want to get is the presenting problem from a client. This is going to be something in their own words. Typically, it's not just one issue, though. I've included two arrows here just to represent that usually a client comes in and they've got a variety of different descriptions of issues that they're coping with or having issues with at the time. This then needs to go and follow a thread throughout the entire treatment plan, which I spoke about in the research course. And now here we are in this course talking about this golden thread that needs to run through the entire document. And this really, when it comes to treatment, definitely needs to be very strict in making sure that things line up. So in this case, starting clear from the presenting problem and going all the way through the treatment modality. In this case, after the presenting problem, you need to make sure that the problem description, the actual signs and symptoms, then are listed out and draw from the presenting problem. I've mentioned those, like I said, here with those two different arrows. Once you get enough problem descriptions, the signs and symptoms, then you can build the diagnoses based on the one that has the most prevalent symptoms and the most severity. Usually that becomes the primary diagnosis. And then you have the secondary diagnosis, usually drawing from some of the secondary symptoms or the ones that maybe are a little bit more mild or are not causing as much impairment. Now let's get down to the treatment goal. So the treatment goal A, should be drawing from the primary diagnosis A. Then you have a separate treatment goal for the secondary diagnosis. So you also, again, want to make sure that things are lining up with both A and B. In this case, the primary diagnosis I've labeled A, the secondary being B. And this should then continue on, that the treatment goal A should line up with the objective A, and treatment goal B should line up with objective B, and so on and so forth throughout the intervention and even into the treatment modality. So essentially there's almost this almost secondary golden thread that needs to make sure that the goals, objectives, and interventions and modality all lines up, and then that then lines up with the entire treatment plan. So couple of things going on, but it's this idea of just making sure that everything is matching up evenly throughout the entire treatment plan. So let's start off with the presenting problem. In some agencies, particularly medical agencies or medical centers, this is often called the chief complaint. Most counseling agencies call it the presenting problem. This is usually best understood as the client's description in their own words or phrases of why they're seeking treatment. A clinician can get at this by simply asking what brings them to treatment or why they've been seeking treatment. I'll typically ask how they've been feeling lately. This will give me plenty of descriptions such as I've been stressed, anxious, overwhelmed. That will help give you some of the key words that you're going to need, as I mentioned in that previous slide, to then help build the secondary kind of scaffolding of what are your symptoms. So by asking them why they're seeking treatment and how they've been feeling lately, that should give you plenty of information. Again, in that first bullet point, you're going to want to document key words and phrases used by the clients themselves. So make sure you're taking some notes of, direct quotations, at least some of the key words. Now, as you obtain that description about the signs and symptoms and reasons for seeking treatment, make sure that you're getting plenty of descriptions. The more descriptions you get, the better your diagnoses are going to be developed and a lot easier to be developed. So rather than them just saying, oh, I've been feeling anxious lately, you're going to ask, and we'll go into this in the next slide here, you're going to probe a little bit further as far as how exactly anxiety is showing up in their life. How do they know they're anxious? What are the signs and symptoms? That's going to help you build a very solid diagnosis. Let's look at an example real quick of just a presenting problem that I developed here, just to show you and emphasize what it might sound like in writing up a presenting problem. So in this case, and you'll usually use words such as the client reports or the client states, things like that. That way you're using their words. So for example, the client reports that that she feels, quote, extremely overwhelmed and stressed lately because of everything that's going on in her life right now. She states, I don't have any motivation and energy anymore and don't feel like doing anything. She further states, sometimes I feel like I just want to run away and be alone for a while. She reports feeling this way for the past several months. The client states that her relationship is hanging on by a thread and that her husband has basically checked out of the relationship and family. So this would be kind of a basic presenting problem description. Now, some agencies will want to have you gather certain aspects of the presenting problem. In this one here, it does have a time frame. It says several months. Other agencies want to have you include, for example, the age, gender, ethnicity of the individual as part of the presenting description. It really just depends on your field instructor and the agency. But for the most part, this is kind of a general description of what a presenting problem is. Now we get into the problem description. So the problem description, it's important that we think in terms of really kind of behavioral descriptions and descriptions that would help us formulate a diagnosis. So let's begin to speak about that. The way you would get at that from a clinician standpoint is one of the best ways is to get behavioral descriptions. What are things that you could see as a subjective observer or as the client stating that they observe in themselves? The way you could get at this is asking them, what happens when you feel depressed? Or what happens when you feel anxious? What do you do? What is different? What do you do differently? How does anxiety impact your daily activity? Or what do you do differently when you're depressed than when you're not depressed? All of these descriptions that they're going to tell you will then help you understand exactly what that, essentially what the criteria are for the depression, the anxiety, or the other symptoms that they're describing. So the more behavioral descriptions you can get, the better off your diagnosis and treatment plan is going to be. Some clinicians, like I said, just stick to the basic word of, oh, the client's feeling depressed, but they forget to really kind of flesh out this idea of what exactly does depression, how does that show up for the client? Because as we know, every client is distinct and unique in the way that they experience those signs and symptoms. You'll want to also obtain specifics about the frequency, duration, severity, and intensity, onset, and chronicity of those symptoms. We'll go on with that in a moment. So for example, if you were to ask what happens when you feel depressed or how does depression impact their daily life, they might say something like they lack a desire to participate in enjoyable activities. They have feelings of hopelessness, helplessness, worthlessness, difficulty sleeping, feeling of worry, nervousness. All of these things you'll want to write down or jot down as their description of the problem. This could also be lack of appetite, increased appetite, decreased appetite. It could be lack of energy. It could be even thoughts of suicide. All of that, all of those descriptions are things that you need to gather as part of the problem description. Again, I can't emphasize enough that the more descriptions you get of the symptoms, the better off you're going to be as far as diagnosis and treatment planning. As I stated, this will help you provide a rationale for the diagnosis, especially if an insurance company were ever to audit your notes or your supervisor were ever to question or audit your diagnosis. You'd be able to say, hey, here's the rationale for my diagnosis. And you'd be able to list off the behavioral descriptions and how long and how severe those are. And it just makes for a solid case conceptualization and a solid treatment plan because you're able to provide justification. As I stated, these problem descriptions can also be part of the treatment plan because they can be used as part of measurable change. So if a person says that they're having difficulty sleeping, it may be that you incorporate into the treatment plan, really striving to get better sleep at night or whatever the case may be. And that's something that you could measure and strive to work to change if that's something that the client wanted to work on. Again, all of those things, behavioral descriptions, really help in treatment planning. So let's go on to the section on developing a diagnosis. So once you have a very solid description of the behavioral and kind of subjective signs and symptoms of what's going on with the client and how they describe that they're experiencing those symptoms, you're now ready to begin to develop a diagnosis. Now, even though this isn't a DSM class, you don't have that till the summer, let's talk about some of the basics of that. So number one, you want to assess, getting back to the behavioral descriptions, one of the easiest ways or one of the most effective ways is to begin to group or categorize the symptoms based on common features. So, if they describe depression and you gain a description of depression, you'll want to group those symptoms under their description of the symptom they're talking about. So if they're saying that they lack sleep, difficulty concentrating, feelings of hopelessness, worthlessness, that's why I try and explore each symptom and then have them describe those symptoms and kind of group all those features together, and then move on to another symptom and have them describe how that shows up in their life and group those together. If not, you're going to have this kind of massive, it's like it's almost like that, a ball of yarn just kind of grouped together. It's going to be difficult to sort out what symptoms match up with what sometimes. So I try and do kind of really methodically, when they talk about depression, for example, I'll ask them to describe it. If they talk about anxiety, I'll have them describe that and what's going on. That'll just help you categorize and group those together. Once that happens, as I stated, you'll hopefully begin to group them up into similar sorts of diagnoses or similar sorts of groups, whether it's anxiety, depression, so on, trauma. You're going to then ask yourself, what are the most prevalent symptoms? So based on the frequency of those particular symptoms and descriptions, how often they occur, how long do they last, how severe are they, when did they start, that will basically define what your primary diagnosis is going to be and then what your secondary diagnosis is going to be. Sometimes I'll just come right out and ask the client because sometimes depression and anxiety are so close to each other, they kind of build on each other, that I'll ask the client straight out, which do you feel you have more issues with? Is it more issues and struggles with depression or more struggles with anxiety? And usually the client's pretty self-aware to say, I actually struggle more with anxiety, but I also struggle with depression kind of along with that. But at least oftentimes they'll be able to tell you which one they feel is the one that's is most prevalent in their life. Don't forget to assess the impact on functioning. So understanding how do those symptoms impact multiple areas of their life. Again, this gets back to providing a rationale for the diagnosis. You need to be able to justify, if this depression or anxiety is only affecting them but not affecting their job, relationships, nothing else, it's going to be kind of difficult to justify a diagnosis, because according to the DSM, it really needs to affect multiple areas of your life or multiple areas of functioning, which is usually pretty easy to achieve. But nonetheless, you'll want to ask, how is depression affecting your job? How's it affecting your relationship? How's it affecting your social life? Once you start asking questions like that, usually the client begins to say, yeah, it's making my relationship difficult, or I'm not seeing my friends as much, or I'm having difficulty concentrating at work. All of those things will help, again, bolster your rationale and justification for the particular diagnosis. You're then going to use the DSM-5-TR, which is the current version, to determine a diagnosis based on the descriptions. So that'll take you back to the actual behavioral descriptions from the client, based on the prevalence, how frequent, severity, duration. You'll figure out which is the most prevalent of the symptoms. Hopefully the client helped you with that. And then you'll begin to look in the DSM according to which are the most prevalent symptoms. And there you go. That'll help develop a diagnosis. Now, for this assignment, for the treatment planning assignment, for this course, I'm not expecting you to develop a really detailed diagnosis. As long as you're well within a large ballpark, you'll be fine. I'm not expecting anything, again, very difficult and detailed at this point in your education, but nonetheless, it's a fun activity to begin to gain those skills. Now let's talk about the treatment goal. As I stated, your treatment goal really needs to pertain to each of the diagnoses. So it really needs to now link back specifically to the diagnosis. A treatment goal typically is a long-range view of what you hope to achieve with the client. So a treatment goal needs to be using broad, flexible language. That's very helpful when you're talking about insurance companies, as well as you want to have a language for a treatment goal that is flexible, that is not so specific that all of a sudden it's very difficult to meet the goal, or you meet the goal so quickly that then it seems like, again, that you should be ending treatment. So I'll give you an example here in a minute, but treatment goals typically, again, use statements that are broad and flexible. Now, they typically begin with an action verb. So these action verbs can be something like reduce, stabilize, resolve, increase, achieve, develop, and so on. So let me, within the statement, then you'll also want to address what you hope to do with the symptoms. So that might be you want to increase something, you want to decrease something, you want to stabilize something. You also want to include in your treatment goal what you intend to do with the functioning of that individual. This will help insurance companies know what you're then trying to ultimately achieve. Now, again, these statements are going to be broad and very flexible, but at least it'll show whoever's reading it kind of what you're trying to do as part of the goal, overall goal. So let's look at some examples here. This one that I came up with, or one that I've used before in looking back at my notes. So this very broad statement that says the treatment goal: reduce the frequency, intensity, and duration of the anxiety symptoms while improving ability to function on a daily basis. So you'll notice I start off with a action verb. I start off by saying I want to reduce the frequency, intensity, and duration. That lets who's ever reading this, insurance company, supervisor, know exactly what I'm trying to do. And then I also include the statement that states what I hope to do with the functioning, or what I hope to do with the symptoms eventually, which is I want to reduce all those symptoms while improving the ability to function on a daily basis. Let's give another example. This one's maybe for depression. Start off with an action verb, alleviate depressive symptoms, and return to previous level of effective functioning. Now you may be looking at this going, whoa, Nate, that's way too broad, or that's, not specific. And again, it's not meant to be. This is a very long range view that I hope to, in this example, alleviate the depressive symptoms. So essentially make them so that they're mild enough that they're no longer there or not affecting the client. And you hope that they return to their previous level of effective functioning. So in the end, it works, it's broad, and it's flexible. Another example is achieve stabilized behavior, moderated mood, regulated speech and thought processes, reduced impulsivity, and stable pattern of daily activity. So as you can see, some treatment goals can actually kind of really be stacked full of different treatment goals within the treatment goal statement itself. In this case, I want to help the client stabilize their behavior, moderate their mood, regulate speech and thought processes, reduce impulsivity, and stabilize their pattern of daily activities, which I hope to do to increase their functioning. So that was the treatment goals. Again, broad, flexible, start with an action verb, talk about what you hope to change as far as symptoms and where you hope to go as far as functioning. So let's go into treatment objectives. Now, treatment objectives need to be aligned with the treatment goals from which they're being derived from. Now, treatment objectives are going to be shaped primarily by the theoretical framework and modality that you're choosing. Now, treatment goals are very broad and flexible. They can pretty much be, no matter what your theoretical framework, they're broad enough to be they can fit in pretty much every one. Treatment objectives, though, really do depend on the modality that you're using. So, for example, the statement that you're going to use for the objective is going to be more specific to a concept or a skill that you want the client to begin to learn and implement. This also needs to begin with an action verb. So these verbs might be, for a treatment objective, you want the client to learn, you want them to implement, identify, complete, utilize, maintain. All these are treatment objective type of action verbs. Let's talk about some examples then of objectives. This could be something with anxiety where I might say I want to have the client identify, challenge, and replace fearful self-talk with balanced, flexible thinking. So as you see here, I may have a treatment goal that was very broad, that I want to reduce the feelings of anxiety and have them increase their daily functioning. The objective statement now would be, in order to achieve that goal of reducing their anxiety, I'm going to then have them as an objective begin to identify, challenge, and replace fearful self-talk with balanced, flexible thinking. So there's an objective. Let's use one then that has to do with maybe bipolar disorder. So I want the client in this case to learn and use relaxation exercises to manage and reduce irritability and impulsive behavior. So as you can see here, the objective is learn and use relaxation exercises. And then I will also include kind of what it's meant to do, which is to manage and reduce irritability and impulsive behavior. That lets the person reading my notes know why I'm picking this particular objective. Another is, it might be as simple as the client will read a book on the topic of grief to better understand the experience of loss. That's a very straightforward objective. Read a book and in order to better understand the experience. So if you see, most of these statements have almost two parts. It's what you want them to do and why they're doing it. What's your objective in that? That objective should then match back up with what you're trying to achieve with the goal, overall goal. Lastly, objectives will have a similar feel to the next portion of the treatment plan, which talks about specific interventions. I'll explain a little bit more, but for now, really objectives are talking about skills and concepts of what you want the client to begin to do, and what you hope to have them do it for, such as reducing something, better understanding, and so forth. So what's the intervention sections? Well, this is where we're really talking also that this needs to be guided by the theoretical framework. So when we're talking about that second golden thread, that the interventions need to be guided directly and stem directly from the objectives you listed and the goals that you listed. So they need to be guided by the same theoretical framework, the same thread. You shouldn't be jumping from kind of one objective using one modality to another intervention with another modality. Again, this needs to follow that same thread. So here we go. Statements again need to begin with an action verb, or a verb usually that's process oriented based on the modality. So let me give you some examples of some statements with regard to describing interventions. So this might be assess, explore, ask, teach, instruct, assign, refer, engage, develop, identify, encourage, monitor. All of these things really are intervention words. It's process oriented, and it has to do with a modality that you're using. Some examples then, specifically, let's say you had an objective that you wanted to have the client receive a medication evaluation from a provider. So your objective was to have the client access and obtain a medication evaluation as an objective. The intervention for that then, and what you hope the client to do then, is to refer the client to the physician for a medical evaluation to rule out any general medical conditions that are contributing to anxiety. So the intervention then is the actual steps that you want them to take to achieve the objective in the previous section. So interventions, the way I would think about it is these are the actual steps at this point. In the actual process that's taken place to achieve the objective. Another example of this would be going along those same lines, that you would monitor the client's psychotropic medication compliance and side effects and effectiveness, and maintain contact with the prescriber. So this is a common goal that I have, particularly with clients that have or are using medications. Is something that I want to monitor, and so I'll have that as part of the intervention, is to monitor their medication. This is another one: teach the client relaxation skills to manage anxiety and have the client apply these on a daily basis. That's the intervention. You want to instruct the client on cognitive behavioral therapy and begin helping the client track or chart the connection between thoughts, emotions, and behaviors using a daily thought record. Again, you can begin to see that the interventions are really specific on what the task is going to be for that individual to achieve the objective that it came from. Another one: assess the client's cognitive distortions and schemas that contribute to symptoms of depression, have them track more flexible thoughts. Ask the client about specific changes in detail they hope to achieve by the end of counseling, and be prepared to discuss their ideas in the next session. This last one has to do with maybe solution focused type of intervention, that you're asking them to think about specific changes in detail that they hope to achieve and be prepared to discuss those. So there's the intervention section. Begins with a verb that's very kind of process oriented or task oriented, and then the intervention is a very specific description of the steps the client or you as the clinician is going to take to achieve the previous objective that you set up. Let's talk about treatment modalities really quick. That you will want to identify what your primary and possibly even your secondary modality is going to be that you're going to guide treatment. This then needs to follow that golden thread and make sure that the goals, objectives, and interventions all follow that modality that you selected, and making sure that you're using the appropriate terminology to describe the objectives and interventions. So for example, I'm just kind of listed these out. If you're going to follow a solution focus modality, some of the key words that you're going to use, or some of the key descriptions, is you're going to ask them, the client, to identify desired changes, find daily or weekly exceptions, identify coping skills that they've used, rate their daily emotions or efforts, and making small changes happen and charting the small changes that have occurred. Those are kind of very solution focus oriented. Let's talk about motivational interviewing. This might be for them to identify or track desire, ability, identify reasons for change, or identify needs for the need to change. You might have them assess their commitment, their ability, and what steps they've taken this past week. And then you would have them such thing as develop or follow their treatment plan, or their change plan, and what portions did they follow and what were they able to accomplish. Moving to behaviorism, you might talk about helping the clients identify the behaviors ABCs and identify and track reinforcers or punishments, implement reinforcers to increase healthy or productive behaviors, and appropriate extinguishing methods to decrease unhealthy or unproductive behaviors. Also behavior activation, such as getting up, getting out, getting moving, increasing behaviors, social interactions. All of those things could fall under behavior, or behavioral activation is a very popular term. Under CBT, you might use such things as identify the ABCs in the client's life, identify cognitive distortions, explore core beliefs, track and record thoughts, emotions, and behaviors, implement relaxation techniques, as well as behavioral activation also falls under CBT. DBT, we'll get into this here in a couple of weeks, but we'll talk about DBT as such things as assess the client's safety level and following their safety plan. It might be words such as implement distress tolerance skills, use emotional regulation steps, utilize their daily diary card to track emotions, behaviors, and coping skills, use mindfulness and present moment skills, analyze behaviors using a chain analysis. And then ACT. You might have them identify and clarify core values, use cognitive diffusion skills, implement mindfulness, practice acceptance and flexibility, track value-based committed actions, increase awareness of unhelpful thoughts, or experiential avoidance behaviors. And we'll talk about those words over the next several weeks here, exactly what those means. But these are descriptions and frequently used kind of words and interventions used with some of the modalities that we've covered or are going to cover this semester. So hopefully this is a helpful list of just giving you some ideas of ways you could help describe some objectives and interventions you would be using with your client to guide treatment. Okay, let's dive into this last portion. So I've got an example here. I've got my made up client, Linus Van Pelt. So for those of you who are Charlie Brown fans, so here we have Linus. Based on his presenting problem that he described, I don't have that written out here, but based on his description, I then gathered the behavioral definitions. So I'm kind of working backward in this snapshot, but it still, again, is lined up with what I first showed you. So let's say, for example, I asked Linus, tell me how, when you feel depressed, what do you do differently, or how does depression affect you? And Linus might come out and say, you know what, I feel down or depressed. I'm sometimes irritable. I don't enjoy activities anymore. I have difficulty sleeping, or I'm oversleeping, lack energy, I have poor concentration, I withdraw from my friends, I have feelings of hopelessness, worthlessness, and I have low self-esteem. Well, all of those behavioral definitions combined really do match up with the description of depression. And that depression then really does need to be based on all of these descriptions. Just merely having the client say, yeah, I'm depressed is not going to be enough to justify or provide rationale for a diagnosis of depression. You really do need to have a good solid list of descriptions that can be observed. This is really kind of what's meant for this portion of the golden thread, is making sure that your behavioral descriptions are matching up with are based on the presenting problem, matching up with the overall diagnosis, which is in this case major depressive disorder, recurrent, moderate severity. So again, this golden thread here, you can't just say, oh, he said he was depressed and then just go on, because depression shows up in a bunch of different diagnoses. So you need to have a behavioral definition of depression to make sure that you're on the right track. Let's talk about then the first goal. Treatment plan goal then needs to be based on the major presenting problem for the very first diagnosis. So in this case, I put down for Linus that our overall goal for our treatment, for as long as we're going to be in treatment together, is to develop healthy thinking patterns and beliefs about self, others, and the world that leads to the alleviation and help prevent the relapse of depression. So very broad, very wordy, but also very flexible, that allow me a lot of room to use a bunch of different interventions. My first objective then, that will build off of helping to achieve that goal of, develop healthy thinking patterns and beliefs, might be, in this case, that I want him to cooperate with a medical evaluation by a physician. I might feel that this depression has been around for so long, or the client feels that medication might be helpful, that my first objective is for them to cooperate with a medical evaluation by a physician. As I stated in the previous slides, we need to make sure then that that objective will help achieve the goal, which in this case, if they go get on the proper medication evaluation or have a physical from the physician, that will help prevent relapse of depression and lead to the alleviation of depression by chance, or hopefully. The intervention from the first objective then that builds from the first objective is that evaluate the client's need and desire for psychotropic medication, and if indicated, arrange for a medical evaluation. So the objective is to cooperate with a medical evaluation. The intervention then is I want to make sure that I evaluate the client's need and desire, and then arrange for a visit to take place. That's the intervention. Objective 2 in this case, so sometimes with each goal you might have 2 objectives in order to kind of help achieve that goal. So objective number 2 is maybe you want to increasingly verbalize hopeful and positive statements regarding self, others, and the future. That one definitely lines up with that first goal. The intervention then in this case will be to assign the client to fill out a CBT daily thought record in which they identify activating situations, initial emotions, identify automatic thoughts, and then identify balanced, healthy thoughts and re-rate the emotions. So that's going to be the intervention. So the objective is somewhat a broad statement that talks about, you want to increase hopeful and positive statements. The intervention is how you're going to have the client carry that out. What are they actually going to be doing? Let's then move on to another example of the diagnosis. So this would be Linus's secondary diagnosis. So in this case, the behavioral descriptions that he mentioned is that he has excessive worry that's difficult to control for more days than not for at least 6 months about a number of different events and activities. He also experiences feeling constantly on edge, concentration difficulties, having trouble falling or staying asleep, and general state of irritability. So these behavioral definitions then line up with the problem of anxiety. So based on the behavioral definitions, I'm able to say, yep, provides a strong rationale for anxiety, generalized anxiety disorder. So that kind of follows that thread there for that diagnosis. Now, the first goal that I want for him to achieve is to learn and implement coping skills that result in a reduction of anxiety, worry, and improved daily function. Very broad language. I want to reduce anxiety and worry and improve daily functioning. Now, the first objective, similar to what I had for his primary diagnosis of cooperating with a medical evaluation, I'm going to do that also for his anxiety. That way, those two objectives kind of line up with each other. The intervention is, in this case, refer the client to a physician for psychotropic medication consultation. So very similar intervention to achieve that objective. And a second objective would be to learn and implement calming skills to reduce overall anxiety and manage anxiety symptoms. So the intervention to that, in order to help the client learn and implement calming skills, the intervention is to teach them the calming skills such as applied relaxation, progressive muscle relaxation, and how to better understand, discriminate between relaxation and tension. So learning how to relax and also learning how to reduce tension, and how to have them apply that throughout the day in their daily life. So not just once a day when they're tense, but maybe relaxation throughout the day, in a variety of different settings. Sometimes I'll have clients use these relaxation techniques in the grocery store, maybe while they're driving certain ones, while they're at home. So not just once a day, but how can they apply them in different settings? And then finally, one of the last things in a treatment plan is identifying the treatment frequency. This oftentimes will be based on the severity of the diagnoses, particularly the primary diagnosis. So, for example, if it's anything within kind of moderate to severe, probably weekly treatment is indicated. If it's anything like mild to moderate, sometimes every 2 weeks will be appropriate. So we got to make sure that that lines up with the primary diagnosis of what's appropriate. Okay, everybody, that is kind of treatment planning in a nutshell. That's a very quick version, as we then will move to the summer semester, where we'll dive much more in depth about this. But this is a good start for you throughout the rest of the semester and into spring semester, as some of you start to take on clients or already have clients. This hopefully provides some really good solid orientation of what a treatment plan should look like, and some of the wording and some of the feel of a treatment plan. Okay, there we go. That is treatment planning, and that is your independent study for the week.